so much, Dr. Seema, Dr. Narsingh. And at the outset, I would like to thank Dr. Manoj Chawla, Dr. Purvi Chawla for giving me this opportunity to speak on this esteemed forum. So the topic today of discussion is going to be IMD and Flozins. And my take is always before insulin. So I'm thankful to God that we are in ever evolving segment of diabetes and we are no more the people or a diabetologist who are starting insulin right after our metformins. So we do have some very good molecules in our kitty to start for our patients. So I don't have to emphasize upon the fact that we are the world capital of diabetes, and we also have in our own very city of Mumbai suboptimal diabetes control, wherein despite having so many good medications, we are keeping average HbA1c of 8.3, which is not that great. Now let's start with pathophysiology. If we talk about omnious octet and various key processes in the body which are responsible for diabetes and its complication, we have to ensure that the medications that we are starting are acting upon all these metabolic processes, and that's where we have magic trifecta. So magic trifecta is nothing but metformin, GLP-1 analogs, as well as SGLT2 inhibitors, and they form magic trifecta, and they're practically working at every pathophysiological pathway responsible for type 2 diabetes. Whereas if we think about insulin, insulin does not address all the pathophysiological pathways. We see that most of the problems in omnious octet are not targeted with insulin, barring that hepatic glucose output and peripheral utilization of glucose are the only parameters where it works. Is diabetes a disease of only rising blood glucose? No, it is a metabolic disease. We are practically seeing every time micro as well as microvascular complication. Organ protection is something that should be at the top of our mind when we are choosing any oral hypoglycemic agents. Why? Because organ protection should be at first point of contact. We are taught hit early, hit hard. So why not choose better oral hypoglycemic agents which are able to give complete metabolic control with organ protection along with robust diabetes control? Diabetes eventually is going to lead to cardiovascular mortality, morbidity, renal diseases, retinal diseases. So what we are looking at is the first bead of the whole necklace, which is going to eventually progress to various metabolic diseases. So when we have such good medications in our kitty, like GLP-1 and SGLT2, why opt for insulin? What are the challenges that we are facing in our day-to-day practice? Despite having good medications, we see that our patients are unable to achieve HbA1c targets. There is a need for multi-organ protection in our patients. There is a risk of hypoglycemia, there is a risk of weight gain, there are risks of renal complications as well as cardiovascular diseases. So we need one medication which is able to target all these pathophysiological mechanisms along with organ protection and diabetes control, and that is nothing but a combination of incretin mimetic drugs along with Flozins, and they are one of our favorites already. So if we look at therapeutic landscapes, the medications that we have for treating type 2 diabetes, these two medications are going to target the whole pathophysiological spectrum more effectively as compared to that of insulin. And I'm sure most of us are already using it in our day-to-day practice. So do all these medications offer cardio as well as renoprotective effect? No, they don't. So only two classes is something that we should concentrate on, and that is cardiorenal protection with SGLT2 and GLP-1 RAs. And why do you think this segment is ever booming? We have multiple new medications coming in this segment. Whether we talk about Wegovy or Zempic, we talk about tirzepatide, we definitely have this as a booming segment, and most of these medications are on our pen. The reason is because it is giving the kind of benefits that we want to see in all our patients. Now, if we talk about guidelines, so if we look at the guidelines, we definitely see ADA and ESD is placing these medications as highly effective medications in controlling type 2 diabetes in the whole spectrum. So insulin mimetic agents have ample evidence. I don't even need to quote it. Most of us know that they work very well when it comes to MEs. Various cardiovascular outcome trials are supporting it. GLP-1 RAs are also working in stroke protection. RAs and heart failure is a known thing that we see that cardiac risk definitely reduces by use of these medications. SGLT2 inhibitors have various trials backing its use. So let's talk about heart failure. Various trials in SGLT2 tells us that cardiovascular protection occurs after use of these medications early on while treatment. So if we look at the various trials, we have TAPA-HF, we have Emperor-reduced trial. These medications can be used in patients with preserved ejection fraction, in patients with reduced ejection fractions, patient with diabetes or patients without diabetes. So in every way, these medications can be used by all of us, whether we are treating physicians, cardiologists, nephrologists or endocrinologists. Looking at the guidelines, so when we talk about guidelines, we know that guidelines definitely support the use of these medications. And as per the ADA standard of care guidelines, these medications are used for the patients with established atherosclerotic cardiovascular disease, patients with chronic kidney disease with reducing EGFRs. These patients are choice of medications for obese patients. So whenever we look at guidelines, they definitely support the use of these medications. Let's talk about what is our patient preference. Which patient likes taking multiple injections multiple times in a day and also monitoring the sugars constantly? Nobody really likes it. So patient definitely prefer oral medications over injections. Quality of life is better with these drugs than insulin. Risk of hypoglycemia is lesser. Risk of weight gain is lesser. We have lesser complex regimen and it does not need multiple pricks to monitor them. So, as I've already said, if we look at the guidelines, we see that these drugs are well placed in all our guidelines. Whether we talk about AACE guidelines or ADA standard of care guidelines, they definitely have a place before insulin for use in our day-to-day practice. When we talk about insulin, insulin is placed for the patients whose HbA1c is more than 9 and those who are uncontrolled on 3 oral hypoglycemic agents. So there are clear-cut guidelines that we can definitely place these oral medications prior to insulin use. Major diabetes guidelines, including our own guidelines, tell us that any patient who reports to us with HbA1c of more than 8 or more than 9, we can choose to start with a dual combination therapy or a triple drug combination therapy for giving a patient well-controlled diabetes. Then why put insulin early on in the treatment when we have such nice set of medications available to us? Yes, I agree. Safety and side effects could be one reason that we should be little cautious of, but it is nothing that we cannot tackle by good patient counseling and educating them. So when it comes to SGLT2 inhibitors, probably good genital hygiene, drinking plenty of water is good enough, and we see patient tolerating the medications very well. When we talk about GLP-1 RAs, cost is one factor. But then these medications going off patent, becoming generic, it makes it available to most of us. So I don't think even cost is an issue anymore. So when we talk about these gastrointestinal side effects that they have, even here the patient education solves most of the issues. We can ask them to take small frequent meals, avoid eating oily, spicy, deep fried, and they tolerate the medications very well. So according to me, regular patient education and monitoring can easily overcome these challenges in most of a patient. To summarize the whole discussion, I would like to state incretin mimetic drugs and gliflozin are optimal choices before insulin initiation in all type 2 diabetes patients. They are multifaceted, metabolic, cardiovascular, and renal benefits are for us to see. There is reduced risk of hypoglycemia and less weight gain. Early use aligns with modern diabetes management, and we should aim at not just controlling sugars but improving overall outcome and day-to-day life of a patient. Thank you so much.